Hi, my name is Tom Manning, and I'm a chemistry professor at Valdosta State University, and I'm going to pitch some of our ideas related to drug development. I'm going to use tuberculosis as an example, simply because we've done a lot of work in this area, published papers, received a patent, have been through various types of preclinical trials. So what our unique kind of approach to this is that we are using formulations where everything is bioactive or chemoactive. They either have a direct bioactivity or a chemical activity, or they enhance something else. In this particular one, it's customized for TB, and at the end I'll mention some other drugs that we've worked with, and I'll also talk about our business model and how this can be commercialized. Okay, so quickly I'm going to mention the business model, and I want you to see this, so as we go through it, you'll understand kind of what we're doing. So what we want to do is have boutique chemotherapy agents for prevention and treatment of various diseases. As I mentioned, we're focusing on TB because we have a lot of data, but the same thing can be applied to some of the other work. We've done a fair amount with new cancer drugs, and you'll see it can be worked there also. Make it in small, large quantities for researchers, right, where we design and provide researchers with unique drugs for their particular disease. Right? So it's a kind of a new approach. And everything is novel, bioactive, chemoactive, and physically active, where there's multiple mechanisms of actions. What the company would not do is take things through clinical trials, but they would partner with those that are interested in taking these things through various levels of development. Okay, so for tuberculosis, this is our particle, and this is the kind of the drugs that would be in there. And what I'm going to do is go through step by step and talk about the different species that are there and why we put them in. As we go around, you can see there are three of the branched amino acids. There's cholesterol, there's a copper stearate, there's vitamin C or absorbic acid. The bulk composition is stearic acid, and cholesterol is close. There is a copper, EDTA, sucrose, glucose complex. There's the antibiotic. We use PEG to trap things and prevent reactions from taking place. There's sodium acetate. There is unsaturated fatty acids, including oleate, and then there's sodium chloride. And we'll talk about each of those and the role that they play and how we design this bioactive material. Okay, so when we put our materials together, as opposed to having a single drug with a single activity, that's the antibiotic, we're adding other things that have bacteriostatic or bactericidal activity. They provide an energy source for the bacteria, which increases metabolism and other cellular processes, and hopefully takes the drug up faster. There are some that are part of the cell membrane, so when we give this as a medication, that it's going to take this in to construct the cell medication, and as a Trojan horse effect, also bring in the medications. We want to enhance existing toxic species, and I'll talk about that particularly with copper. We're going to generate some reactive oxidation species like hydroxy radical. We're going to indiscriminately bind proteins inside the TB, and that's a method of slowing it down. There's a chemical aspect to ours where it's non-polar, so it'll stick to the membrane of MTB, which is dominated by glycolic acid, which is non-polar. And in some cases, we're adding things to prevent reactions from happening until they reach the spot that we want to have them react at. Okay, so the major composition is stearic acid, C18. It is part of the cell membrane in different mycobacteriums, which means that it's going to be taken into the bacteria. It's also used as an energy source in MTB. So these two things play into the Trojan horse effect. It should be viewed as cellular debris by macrophages, which means that it will be taken into the macrophage, and it has the various species trapped inside it. It gets digested in the macrophage, right, the alveolar macrophage, in which point it releases all the species that are inside. The reason why we chose stearic acid over some other fatty acids was because it's a solid, and it can hold other components. It has a low solubility, which means it will slowly dissolve in the system. So the idea is that this is inhaled nanoparticles, and then they're in your lungs where the macrophages are, and the macrophages digest them. This increases the efficiency of drug delivery quite a bit. It depends on how we do our calculations, but it could be anywhere from 50 to 500 times more efficient than taking something by an oral dose or an IV. Okay, so just a quick image. If you inhale nanoparticles and these could be part of an aerosol that are 30 to 50 nanometers that have the drugs inside, that the macrophage will ingest them. We want to keep the nanoparticles small enough so the macrophage will ingest them and it can impact TB and hopefully not the macrophage as bad. Larger particles could be ingested, but they would likely kill the macrophage as well as the TB. So we want to have them small enough so that we're primarily impacting the TB and not the defense system. Okay, so one of the things that we put in here is sodium chloride. That's added at various levels, right? And sodium chloride is a strong electrolyte, likes to dissolve in water. So by putting that in there, we can control how fast the stearic acid, which has a very low solubility and a very slow dissolution rate, how fast that actually dissolves. Okay, so it's inert in the body, right? Your body has sodium chloride and we're not adding very much, but more or less sodium chloride can control, whether it's days or weeks, how fast that stearic acid dissolves. We include PEG, and we've decided on 3350. If you get much bigger than that, solubility is very low. If it gets much smaller than that, they don't form the aggregates. And the particular thing that we're using this for is we wrap our copper complexes and our vitamins, particularly our absorbic acid complexes in it, to prevent unwanted reactions. Okay, so copper and vitamin C can both undergo oxidation reduction. And so by wrapping it in PEG, it slows that down or stops it. I should point out that we have used PEG in some of our antibiotics for TB as a protectorant. We ended up publishing a number of papers because we had some good results, and we also received a patent on it. Although the PEG is definitely it's an inert carrier, but it's a protector for other species. Okay, cholesterol we include. So it's a nutrient, right? It accelerates cellular processes, which should increase the drug uptake rate and the efficacy. So when Macrobacterium tuberculosis infects cells such as macrophages, their survival is dependent upon the accumulation of cholesterol. So by adding cholesterol and having it inside the macrophage, it should enhance some cellular features that will allow the drug to be captured and be more effective. And so I should point out there are a number of papers pointed on this. With just cholesterol, TB can survive, as the bottom one shows, on surfaces that are completely inert. So this is a food source for us. It's not just another additive. Okay, so copper has well-known toxicity towards Mycobacterium tuberculosis. The problem is that you don't want it to accumulate in the body. You want it there at very low levels, right? Copper is natural in your serum at about 2 ppm. And you also don't want it floating around free because it's very quickly going to bind to a protein. So we wrap it in EDTA, right? And then it goes into a complex that contains both sucrose and glucose. Sucrose is included because it's non-reducing, it helps protect the copper. Glucose is included because it's an energy source for the bacterium. And so this again is going to enhance uptake rate. It's a fuel, it's a Trojan horse, the copper's trapped inside. Once it's inside the TB, the bacterium, and it starts to dissolve, TB is released, and it can bind proteins, right? Or it can generate reactive oxidation species, right? And just a quick example, right? So it can bind any protein on the surface of or inside of the TB, but it's protected by the EDTA, sucrose, glucose, along with the PEG aggregate until it gets there. Okay, copper has an affinity for nitrogens and sulfurs, so the proteins either stop working or they don't work properly. Okay, we also include zinc stearate, right? Zinc is an essential nutrient, but we put this in here to help disrupt the stearic acid matrix, the actual composition, so that it impacts the dissolution rate. And it also adds additional charges, so in the formation of micelles, or larger aggregates, that zinc plus 2, plus all the electronegative elements it tracks around it, kind of gives a shifts in polarity, and it revolts in a slightly more polar, but still non-polar type composition. We want a non-polar component to stick to the TB membrane, because the TB membrane is largely composed of mycolic acid, which is non-polar. Okay, so absorbic acid, there are papers in the literature that show that absorbic acid, vitamin C, has impact on, again, the bacterium, Mycobacterium tuberculosis. It is either toxic directly, or it enhances the efficacy of other drugs. The problem is getting it there. If you take vitamin C as a tablet, right, there's a number of levels of inefficiency. First off, the bacteria, the molecule has to make it to your lungs, so it has to go through the intestines. It can be distributed throughout the body, and then it has one specific spot it has to end up at. So there's a very small percentage of it will actually end up there. The second inefficiency in that is the reactivity. Specifically, ascorbic acid likes to undergo oxidation and reduction, and it can also bind to things. But if it undergoes oxidation and reduction, then it's going to start losing its efficacy. So we want to package it. That's why it's in PEG. And we want it to go into the TB where its efficacy can be directly felt, right? And it's a much higher level of efficiency. So maybe the vitamin C by itself doesn't knock out the TB, but it weakens the TB, so the other things will have a greater role in mechanisms of action and stopping the bacteria. Okay, so oleic acid, right? It is a unsaturated fatty acid. If you look at the chart below, it actually has a fair amount of toxicity towards mycobacteriums, right? Its similar one, the linoleic acid, is also fairly toxic, although at a slightly different pH. So this would be included in a steric acid matrix, right, at a low percent, maybe 1% or 2% of the total mass, as basically an irritant, right? It has toxicity, it's going to impact the TB, it's going to weaken it, and hopefully as it weakens its immune system, it will allow other things to be more voracious in their attack on the bacteria. Okay, so acetate, the primary reason we put acetate, sodium acetate, which is a strong electrolyte, is that we can control how much stearate we form, right? It converts steric acid into stearate. Stearate with a carboxylate, -1 charge, has a slightly higher water solubility and is more likely to form aggregates, kind of loosely form micelles. So that's important. The second thing is that acetate is actually the product of some cellular processes in TB. And so the TB either consumes them again or tries to get rid of it, but the buildup of the acetate is going to actually form a nutrient in a way, and it can block various processes from taking place. Okay, so branch amino acids, again at a low percent, maybe 1%, 2%, there's 3 of them, leucine, isoleucine, and valine. And so they are also a limiting nutrient. And so if you put them in there, you can clog up the system, right, in terms of what role they need to play in TB. And so as a nutrient, right, you can shut down some processes, and again, I'll let the literature talk about it in detail, that these 3 amino acids can do that the other 17 common and some of the uncommon ones can't do. Okay, so let me make a suggested formulation for latent, active, and resistant TB. I should point out that we have the masses up there. They're ratios of how we mix things when we make small amounts. They're not actual dosages. We assume that the dosages on an inhalation would be, much lower than a normal tablet, maybe 1/50th or 100th. And we should point out that steric acid or fatty acid compositions can be ground into small, nanoparticle type sizes. Okay, so the first one is latent. Roughly 90%, over 90% of all people that have TB have latent TB. Okay, so what you'd like to do is to reduce the dose, and you'd like to reduce the number of dosages. And so that's the idea behind inhalation, is perhaps to get it to maybe a once a week situation, because the macrophages are going to consume the drug directly. There's not all the inefficiencies that come along with tablets. And so you can see that steric acid is our dominant species. That's what holds it all together, right? And then you have the isoniazid. And what we did was we looked at the CDC recommendations. There's several different recommendations for treating latent TB, and we just went with isoniazid because it was the simplest, right? And then we have our other species that are in there, right? And you'll see at the bottom, ascorbic acid and the copper species are both wrapped in PEG. But the other species that are in there at lower levels. And so that you have this multi-pronged attack on the TB. Some weaken the TB, some accelerate cellular processes in the TB, some allow the drug to stick to the outer surface, right? There's a number of things taking place there. And so hopefully, rather than having adults or children take large tablets on a daily basis. This, for example, is a daily thing over the course of 9 months, that they might have an inhalation every week or two. Okay, so this is one for active TB, right? And you can see that we again reference some of the CDC work. The first one has 4 antibiotics in it, along with steric, and then the customized other species that are in there, each playing a role. And this again would go into the lungs as inhalation, and then it switches to going to just 2, rifampicin and isoniazid, along again with the different species, right? And this, in terms of the species, follows the CDC recommendation. It's just that the dosage would be much less, and it would be a direct impact by going into the lungs. Okay, so recently there's been some work with the with drug-resistant forms, multi-drug resistant, extremely drug-resistant. One of them involved 3 antibiotics that you can see that are right below steric acid on the left-hand side. Bedaquiline is the most recent one to come to market. And this again has the different species that you would use to enhance their efficacy, right? And so all 3 species could be worked into the dust, and that would replace what's on the left, right, is a tablet that's taken daily that has terrible side effects. So hopefully by dramatically lowering the dose, say if we went to 1/50th the amount entering the body, then the side effects would drop dramatically also. And by only having to take it every few days or a week as opposed to on a daily basis, that would also lower side effects and also lower the actual cost of the drug. On the right is just for bedaquiline, and you can see that that's fairly simple, compared to the other one. There's only a single antibiotic in it. Okay, so just to kind of go over it again real quick, in one particle there would be multiple species that each play a role. Some, such as the antibiotic, is a direct attack on the TB. Other ones enhance it or provide their own level of toxicity. For example, copper and vitamin C and oleic acid bring some toxic characteristics directly to the TB, hopefully weakening the system. Some of the other species, like acetate and their branched amino acids, can indirectly bring toxicity by either jamming up or accelerating certain systems. And then we have things like the sodium chloride, which help with the dissolution rate. So is this a for one drug application? No, we think that we can customize the design for other types of diseases. For example, we've just had a fatty acid-based drug go through preclinical trials with the National Cancer Institute, right? And the idea is that it worked fairly well, or very well. And so again, if you could lower the dose of the chemotherapy agents that are used to treat cancer, for example, cervical cancer is common with TB and HIV, then you would have less side effects. And this could be, injected or applied, localized at a specific region as opposed to being taken as an IV where it hits the whole body. It could also be used, for example, as a malaria drug. We've done a little bit of work with that where the ingredients are different, but the mindset's the same, and then we're putting in bioactive species that attack the parasite that's associated with malaria. We also are working with one with a neurological drug that has been in clinical trials for Alzheimer's, been looked at for multiple sclerosis, etc. And with some specific bioactive ingredients that varies with the specific neurological condition, right? The idea is that rather than having a single dose, a large area under the curve that exists for a short period of time, that we're flattening the area under the curve so that there's a low, for example, something less than a nanogram per mil over a long period of time with the drug inside the person. And this may be a better way to treat the disease than having a single high blast where much of the drug is wasted and results in side effects. So the business model, right? So first is we are in a process right now of finishing a patent application, intellectual property, on the idea of bioactive compositions. So our goal is not for us to bring all these things into the clinical realm. We can't do that. That's, there's specialties out there. So we would design them and then work with partners to hopefully bring them out. We'd like to identify key diseases where slow release can be used as a preventative measure, right? You can almost view it as a chemotherapeutic vaccine. So maybe there's someone that's at high risk for malaria, or someone's at a high risk for cervical cancer, and they can have a low level of the drug in their system, with an implant of some sort, either implant or an inhalation type thing, and that keeps it from developing. We have to optimize the synthesis process and formulations for the nanoparticles. So our concept is a boutique chemotherapeutic approach where bioactive formulations are made on large and small scales. So maybe there's a research lab that wants an idea for a specific way to treat a certain type of disease. We can design it, make it, and ship them 2 grams. Maybe there's someone else that says, we like your idea, we like the fact that you want intellectual property, we want to order 100 pounds a year from you, as nanoparticles in containers. So it's more a chemical synthesis model as opposed to taking something directly through clinical trials. So I'd like to say thank you, and again, my name's Tom Manning, and that's contact information.